I'm Julie Marita. I'm the Commissioner for the Chicago Department of Public Health. And I want to welcome you to this session today to discuss healthcare as a right or as a privilege. And I think what we'll do today is frame this discussion around the social contract theory. And I'm hoping that we will, in the audience, get an opportunity to look at the paper that was written by Bill Kling and Emily Steele before you came today. But if not, we'll cover some of the topics that were addressed in the paper during the session today. I want to thank Michael Pagano, who's the Dean and Program Director for UIC Urban Planning and Public Affairs here at UIC, and Chancellor Emeritus Terry Mazzani, and also President Tony Preckwinkle for inviting us and for hosting this event. I also want to take the opportunity to introduce the different panelists. We have Bill Kling, who is Assistant Professor of Health Policy and Administration at UIC School of Public Health. And then Emily Steele, who is also a Clinical Assistant Professor of Health Policy and Administration at UIC School of Public Health. And then Norbert Riedel, who is the President and CEO of Actinix. And then Dr. Terry Vandenhoek, who is a Professor and Chair of Emergency Medicine at UIC. I think, so what I'll do is review a little bit about the format of this session. Each of us will talk about for 5 to 7 minutes to just give a little overview of our thoughts about social contract theory. And mine is mainly a reaction to the paper itself. And then after that, we'll have a discussion among ourselves, and then we'll open it up to question and answer at the end. There will be opportunity for you all to ask questions and engage us, but it won't be immediately. So bear with us on that. So just as background for myself, I have been in the Health Department of Public Health for 16 years. And the majority of my time in the Health Department has been spent doing immunization work. And so reading Bill and Emily's paper, there was a lot of things that really resonated with me. And I was also actively involved with our Ebola response in the past year. And so again, many of the things that they commented on in the paper were very relevant to me. But when I looked at the paper itself, I thought it was very interesting because the references were made to different social contracts within government and the public over the past. So there were references made to Medicaid and Medicare, but also to vaccine requirements. And to me, it was interesting to think about that because I thought, related to those activities, there's been some evolution related to government insurance companies like Medicaid and Medicare. And also there's been some evolution that has occurred as it relates to vaccine requirements as well. So I thought I'd just talk about that a little bit. And then talk about some opportunities that I think that have arisen as a result of the Affordable Care Act in terms of social contracts and other entities that aren't traditionally thought of to have social contracts with the public. So just from my perspective, I think that the Medicaid and Medicare are great examples of social contracts with the government and the public. And I think the Affordable Care Act takes that to a different level because it then puts responsibility on different entities, not just the government. So it's employers, and there's also personal responsibility. So employers that meet certain criteria are expected to provide for health insurance for their employees. But then in addition, individuals in the public are expected to purchase their own healthcare insurance or pay consequences or fines as it relates to their income tax. So I think that there's an evolution that's occurred over time related to insurance and expectations for individuals and government and also employers in terms of provision of healthcare insurance. In terms of vaccine requirements, what I think is really interesting is these vaccine requirements stem back to the mid-1800s. The first vaccine requirements were put into place related to smallpox. So they were put in place to prevent the spread of disease within schools, within communities. And so the government imposed these requirements on individuals, and individuals gave up their right to decide whether or not they wanted the vaccines, they wanted their children to go to school. But over time, what we've seen in the recent past is that there was a strong resistance to those vaccine requirements, and many states actually developed exemption policies that allowed the public to exempt out of vaccine requirements. And so some states had personal belief exemptions or philosophical exemptions that were allowed for individuals who were not wanting to get vaccinated. And then, which led to actually larger populations of people not being vaccinated. And And as a result, there have been many outbreaks, both in Europe as well as in the U.S., related to a form of vaccine-preventable diseases that had almost been eliminated in the past. And what I think is most interesting and kind of timely right now is that we can see the outbreak of measles that occurred in Disneyland this past year prompted a significant response from the state of California, in that they revised their school requirements to eliminate the potential for personal belief exemptions or philosophical or religious exemptions. So now the state of California only allows medical exemptions. So where the pendulum had swung in one direction, allowing more exemptions, the pendulum is now swinging back to prohibit or to limit the number of exemptions that have actually occurred. And you can see that playing out here in the state of Illinois as well, because you can see that in the state of Illinois, what's happened in the past year is that we are now allowing individuals who want philosophical exemptions to actually fill out a form that's completed by a physician that demonstrates that the physician has had a conversation with individuals about the risks and the benefits of vaccination. So that's an evolution. In terms of the Affordable Care Act, I have 1 minute. So what I wanted to say is really, I think that there's opportunity with the Affordable Care Act to put in the hands of healthcare systems as well as insurance companies to deal with population health in a way that they never have before. So there's an expectation that safety net hospitals do community health needs assessments, so to determine what community health needs there are within a community, and then also to address those needs with their community benefit dollars. And so now healthcare systems and insurance companies have some expectation to address population health issues, which they haven't really had to in the past. And so I think while Medicaid and Medicare started a nice foundation for provision of health services, Affordable Care Act now is allowing for there to be more opportunity for health systems and insurance companies and employers to actually play a bigger role in assuring the health of the public. So I'll stop here and then turn it over to Bill Clinton.
Well, thank you. Whoa, that's a little bit loud. I certainly appreciate the opportunity to be here, and I'm very honored to be sitting next to the Commissioner and the rest of the panel. So thank you. I teach in the School of Public Health, and my areas of teaching include policy, leadership, and law. And all of those areas have kind of come together in the formation of this paper, and Dean Pagano gave us the opportunity to draft the white paper to kind of provoke thinking. As a practicing attorney for over a couple of decades, most of my practice was in the public sector. So I represented school districts, municipalities, park districts, community colleges within the public sector. So the way my mind thinks is really how do we engage this conversation with individuals' rights and responsibilities vis-a-vis the government's limited rights and responsibilities, or broader rights and responsibilities, as the Commissioner was just mentioning with vaccination. So I came to this paper with the concept of kind of provoking thinking around kind of almost using a legal model of the social contract. So thinking of the social contract as an actual contract with benefits of the bargain between individuals in the society and the government that's meant to protect. Now, it's throughout the history of this country, the balance of individual rights and government rights has been at the cornerstone of how our government operates and how our individuals go about their daily lives. I mean, we think of life, liberty, and the pursuit of happiness, and those are the undercurrent, the cornerstone by which we operate our society. So the government then plays a role in regulating certain activities to address the needs of the individuals within the community and within society at large. I was challenged to study social contract theory, and we had Professor Alexander provided some great insight to us in terms of broadening the context of this concept of the social contract theory. My approach was looking at kind of the individual and the government. I think Professor Alexander gave us some insight into looking at the power struggle historically between individuals and the government. And so when you think about a legal contract, as I was trying to couch the paper, the concept of individuals and the government kind of being on a level playing field, I think Professor Alexander gave some great insight to say there may be a power struggle. The individuals in our society may not have as much power and authority as the government. It's not quite a level playing field. Dr. Lumpkin also commented to me about the paper that in addition to individual rights in the social contract, we should be looking at corporations and nonprofits as part of the infrastructure. And certainly that is what we do in the work of public health. We bring all of the stakeholders together, so it's very important. With regard to specific issues discussed in the paper, certainly there are examples of where individuals have given up their rights vis-a-vis the government. Vaccinations, as the Commissioner mentioned, is a great example. The astounding one, for me, is this Ebola response, where our government actually restricted travel and required people coming in from other nations, affected nations, to go into certain parts of airports to be specifically tested and held for a number of hours. That's unique. It has not happened very often in the history of our country where government has restricted travel. It's a big deal. And I think the issues around vaccination are also relevant. Just real quick before I finish, the other examples that we use in the paper, and I look forward to you looking at the paper and providing some feedback, is looking at the environmental regulations. I thought the panel this morning did a great job of linking public health and environment and looking at, remember that the police power, and I need to stop, but the police power of our government is about protecting the health, safety, and welfare. And our environmental laws are couched in those terms. So I'll comment more on that later. Thank you.
Hi, my name is Emily Steele, and I'm also a clinical assistant professor in the School of Public Health at the University of Illinois Chicago. It's a lot to say. I also had the privilege of writing this white paper with Bill Kling, and one of the things that struck me about social contract theory is really the willingness of a set of individuals to give up some of their rights for the greater good, for this understanding of a greater society where people can have a greater difference. And so in thinking about healthcare as well, this idea that living in a society, we gain benefits from being accountable to each other and being accountable with each other. The thing that struck me from Professor Alexander's comment on our paper was this idea that in the traditional sense of social contract theory, we're thinking of all the individuals as equal, as sort of on a level playing field. And we know that in the United States, with government or with employers or organizations as being seen as also individuals in society, there can be these inequities and inequalities that exist. So to me, thinking about healthcare, it's thinking about how do we align the incentives of all these different groups that we have in the United States to provide the best outcome that we can. My background is in organizational behavior from a school of business, and so for me, a lot of the arguments that I make, a lot of my research is looking at individuals and organizations. How do they interact? How do they behave? How does the organization or factors in the organization impact their behavior or attitudes in that organization? So for me, in thinking about healthcare, it's also interesting to think about the employer as a potential source of intervention. If there's a way to align the incentives of the employers and the employees so that we can enhance the well-being or promote the health of the employees and sell it as being beneficial to the employers as well. Thinking about bringing in community organizations or governmental organizations so that we can align the incentives of all these different groups to really fulfill the needs and the healthcare needs of the citizens in the United States. So to me, what was interesting about thinking about social contract theory, what is it that we give up? What is it that we give back? Thinking about the different stakeholders that we have, what is it that how could we use employers where employees spend maybe 8 or more hours of every day? How could we use that as an intervention site to try to increase wellness? Do they have healthy options in their cafeteria? Do they have the ability to get up and move around instead of sitting at the desk all day? And I think Professor Alexander made the point that many employers may not see this as something that they want to invest a lot of money in. So then the question is, what is the benefit that we as a society get from having a healthy workforce? What is the benefit that employers have of having employees who aren't sick, who aren't absent, who aren't turning over because of physical injury? Some of my research looks at certified nursing assistants in nursing homes, healthcare centers. And one of the other interesting things to me is that our healthcare providers are responsible not only for providing for their employees, but also for providing health care to the rest of the nation. So if we have certified nursing assistants who are frontline workers who are sick because they can't take a day off or who are ill, then what does that mean for the health and well-being of people in these long-term care facilities? What does it mean for the health and well-being of individuals in nursing homes? And so it's interesting that when we start thinking from a systemic point of view, how can we align all these different groups to really make sure that we're providing for the health care of individuals, but thinking about the health care of our society and the benefits that we all reap from having healthy citizens. So I think I will just cut it off there, but we'll talk more about that later. Nice to meet you.
Okay, good afternoon. I'm Norbert Riedel. I am the CEO of a biotechnology company based in Evanston called Aptinyx. Prior to that, I was Chief Science and Innovation Officer of one of the largest healthcare companies called Baxter International. And along this continuum of discussion that we will have as it relates to ultimately delivering healthcare, and is it a right or a privilege, my focus, first of all, as a European, with my upbringing and my very frequent interactions with European countries, for me, the debate is a very strange debate because I do fundamentally believe that we all have a right to healthcare and we have a responsibility to behave properly, to take advantage of innovation in healthcare without abusing the system and burdening the system unnecessarily. But back to where I believe my thoughts and commentary can fit into the debate we have here, it really is very much at the front end, namely developing therapies. So when we talk about vaccines, when we talk Ebola, or whatever else there is, it eventually all comes back to us as the United States being the strongest innovator in healthcare and in new therapies. And when I came to the country as a postdoctoral fellow, which is a long time ago in 1984, I was amazed by the academic excellence we had in the States. But I was probably more intrigued even by what I call the fluidity between academic innovation and the translation of academic innovation into improving the human condition. And that is truly, I believe, a very, very unique attribute we have in our country, of there being a very, very, I think, comfortable back and forth between industry, in particular healthcare-related industries, and academic excellence. And from a very early point on, I decided to not stay strictly in academia for academic research purposes, but to focus on what I describe as translational research, namely taking innovation and bringing it to the bedside, bringing it to a patient. That, of course, was then the path I took, and literally throughout my entire career, I was always very focused on remaining in very close alliance with academic centers of excellence. Here in Illinois, that is, of course, the University of Illinois system, but it's also the University of Chicago, Northwestern, some of the very, very, very best academic excellence and medical excellence we have in the country. And the contract I actually focus on, because we talk about contracts, is really the contract of academic research and discovery and the responsibility we have to translate it into meaningful contributions to society. And in my industry, that simply means taking those innovations and develop innovative, differentiated therapies for patients with significant unmet medical need. And it is no mistake that Aptinyx, the company I work for now, is completely focused on innovation that actually started at Northwestern, was spun out of Northwestern, and has been hugely successful, including a recent sale we had of our company to a very large healthcare company called Allergan. But the focus really is twofold for me. It is a very close interaction with academic centers of excellence to spot and identify promising, potentially disruptive new ideas and take them to the marketplace as quickly as we can. And in this contract of affordable healthcare, my focus is on truly developing therapies for which there is a very clearly recognizable unmet medical need, and where we can truly differentiate outcomes and make that evidence-based, meaning clinical studies need to prove that truly we make a significant improvement compared to existing therapies in the marketplace. And that's the focus. I am not spending any of my time on me-too drugs or on redoing what someone else has already tried. It's really a matter of differentiation and meaningful contribution to society in the form of addressing unmet needs that patients have. That could be in neurological disorders, it could be in vaccines, for which we struggled, of course, with Ebola, as you well know. It could be in many different areas. And so the focus is really on translation of academic excellence and differentiation to maintain the competitive edge we have in the United States, because I think we do that better than any other nation that I have actually spent time with.
Good afternoon. My name is Terry Vandenhoek, and this has been a wonderful forum, and I'm very thankful to be part of this forum this afternoon. So my background is emergency medicine. I've been head of emergency medicine at the University of Illinois for the last 5 years, and I've been in Chicago many more years before that. I was at University of Chicago. And so emergency medicine is a specialty that we see where all of the bad things happen. We know where the car accidents happen, where the gunshots happen, where the heart attacks happen, where strokes happen. And I think that in the era now of population health, there's an amazing opportunity to empower our communities through what we see and data. And so in the last few years at University of Illinois, we partnered with other emergency departments to do things like HIV screening in the emergency department. We're starting a new NIH-funded project to screen for hypertension in the emergency department and do some innovative things to get people into care better. So there are projects like that we're doing on asthma as well, starting in the emergency department and then helping to connect, bringing the community back into the hospital to provide better care. There's a project that I do want to highlight a bit that is called Heart Rescue, and it really amounts to a social contract that was created a couple years ago, and it's exciting. It's funded by Medtronic Philanthropy. There were a group of emergency departments that came together and said, we want to do more than just watch cardiac arrest patients come into our emergency departments. We want to collect data. And this is a grant to help collect data. There are 6 states that have a grant like this. We competed with 17 other states for one grant, and everyone said we were crazy for putting this grant in. But I think that it was a tribute to all of the people that came together and said, we're invested in a social contract here, that we're going to commit to collecting data about the leading cause of death in Illinois. There will be about 50 people just in this day today that plan on having a normal day and are going to have a cardiac arrest. Their chances of surviving are less than 10%. If somebody sees the event happen and does CPR and does the right steps, it's pretty simple. Their odds of surviving increase by 2, 3, and maybe up to 5-fold. And so the willingness to act on behalf of a neighbor or relative is really important in this disease. And so part of the social contract was to say, okay, we're a group of hospitals, and now Illinois Heart Rescue is up to about 50 hospitals in the state of Illinois that are partnering with communities that surround them and the fire departments and paramedics that work within those communities. And some amazing things start to happen. You go into community settings and say, you have a very high incidence of cardiac arrest here in this neighborhood, and there's nobody doing bystander CPR. The average percent of people that recognize a cardiac arrest and do bystander CPR in the United States is about 30%. In Seattle, it's even much higher. We have many census tracts in Chicago and in Illinois that have 0% bystander CPR. And so we are looking at ways to, as part of that social contract, go back into the community and say, how do we work with you to do this better? We're telling you there are a lot of people dying here. There's been some interesting conversations. You talk to neighborhoods, and they say, well, I don't know if this is a good week to train us in CPR, because we've had a couple people die of gunshots this past week. And then you have this conversation that goes like this, that do you realize that in just 10 days, there are more people that die of cardiac arrest in your neighborhood than will die of gunshots in the entire year. And so let's talk about this more, and let's talk about how do we empower you to do better. And I think we have many areas now that have actually more than doubled and even tripled cardiac arrest survival. And I think that it's a tribute to what can happen with a public-private partnership and a social contract. So thanks.
Great, thanks so much for your comments. Can you someone remind me how much time we have now for discussion among the panel?
Yeah, about 33 minutes.
33 minutes.
Total, but 15 minutes of questions after.
So we have about 18 minutes, so just how's that for a quick math? So I guess what I'll do is, maybe I'll kickstart it because that's my job. It's very interesting hearing all of your perspectives because we come from very different places. And one of the things I'm hearing is that there's this balance between rights and responsibilities, and that healthcare, having access to healthcare is a right, but along with that comes some responsibilities. So I think that it's a very interesting common theme that I'm hearing among the group here. And I also feel like there was an interesting connection between motivation, what motivates or what incentivizes different entities, whether it's individuals, if it's the government, or if it's employers, to actually take on the responsibility to address healthcare either for themselves or for their employers or for the public at large. And so I guess I just highlight those as common themes that I'm seeing. The other thing I find very interesting is, Terry, your example of the public-private partnership in terms of addressing this need in the community, and that it made me reflect back. A couple months ago, I attended a fire department celebration of what do they call them? They're people, firemen and the community who rescue people. And so many of the situations were individuals who actually all the people who collapsed with heart attacks in the field, many of them were present at this award ceremony, and bystanders who resuscitated them, and then also the fire department staff who actually helped them to do that. And I think it really is an example of how when the community partners with the government, CPD or CFD, that we can really make a difference in terms of people's lives. So I think, but it also, there is this responsibility of the public to step up and be willing to accept the training and take that responsibility on, so when they see someone collapse in the field, they're able to respond. So I think those are things that I think are very interesting. And then Norbert, I think your perspective about taking innovation and applying it, and I feel like that's what I have done in public health also, is learn about public health principles, but take it to the local public health and department and actually apply the principles to actually try to make a difference in terms of public health overall. So I'd be interested in hearing you expand upon that a little bit in terms of work that you're doing in the developing world, where access and innovation may not be as readily available as it is here in the United States. So I'll pause there and see if people want to react or respond or elaborate on things that they've said.
I was intrigued by your comments, and one of the things that we didn't necessarily address in the paper, but I think is kind of the next level of a social contract, is this concept of data. And data on individuals. I picture a time not far from now, and the technology's there already, where our medical records are embedded in our arm on some chip. And when we go into the emergency room, the doctor, or the nurse, scans it, and there's your whole history. I mean, we're not far from, I'm sure the technology's there to do that already. And so we have this next gen of, this issue of the social contract being, we have all this data that we're collecting on individuals, and what's the government's rights to use that? I see Michael Gelder in the room, who is the governor's chief medical, I forget what your title was, but
Senior Policy Advisor.
Senior Policy Advisor to the governor, looked at this issue about technology and innovation and the awesome responsibility of government to collect that information. As just a quick example, and I'll turn it over. If you take a foster child in the state of Illinois, I deal a lot in the community, and if you take a foster child in the community, the data on that foster child is in many different government agencies. And they all have different databases that they use. So there's 5 or 6 data sets on this poor child, and none of those data sets talk to each other. And there's need for innovation there. And I would look forward to hearing about how you see that kind of data collection as being a very important social contract.
Yeah, so maybe I go next. So to your question, I can answer it based on the experience I had when I was at Baxter, because Baxter as a global healthcare company operated in many, many countries, including developing and evolving nations. And every time I traveled there, I realized, number one, and I don't think we appreciate it enough in our country here, that it is a privilege to have access to the kind of healthcare we have in this nation. Because when I traveled through Vietnam for quite some time, there were days where I asked myself, if I had, for example, a cardiac arrest right now or an infarct, I would be doomed. That would be pretty much the end of it. Right? And so we have become so accustomed to that being at our disposal all the time that sometimes I think we forget it is a privilege to have it. It is a right, but I think it is also a privilege to have it. On the data collection, I think, to your question, so I think where we are getting better is at the interfaces of information technology, physics, medicine, chemistry, biology, because we are tackling most problems now in a very interdisciplinary way. And I think when you look at other industries, the degree to which they have automated data and data management makes healthcare look like we are living in the Stone Ages. It is so archaic, and because it is so archaic, it is in many ways so repetitive, because you can't look up when the person got their last CAT scan or when they had their last blood draw. And so we basically, for a number of reasons, just escalate the attention to patients, often with healthcare, that I think is excessive. It does contribute to us spending 70% of our GDP on healthcare, when other nations that have universal healthcare and are developed are spending 10 or 11. And I don't think the easy answer is that because their medicine is socialized and therefore it's not as good. I do not ascribe to that. I do not believe that that's a fair comparison. So on data collection, I do believe we are very close to what you described, namely that you have your entire health history on a portable chip, and that it is a very common engagement with your healthcare provider to actually look at it and optimize the degree to which you are not being treated for whatever the reason is that you actually present yourself to that physician for. And I think we have long ways to go, but I also do believe that we have the technology to do it. It is not a technological barrier. I do not believe that.
So I would actually agree with you. I feel like as a public health entity in the city of Chicago, we are ever seeking data, and we keep looking toward healthcare system data as the optimal source, because it's timely information that is being collected routinely in electronic medical records in the vast majority of healthcare settings, and yet pulling it off. So the data collection piece is not so problematic. But pulling together the data and the access to the data, we're really experiencing these challenges. So I would concur with you.
We must be cautious about individuals' rights to privacy, and that's why HIPAA, was enacted. I mean, we need that information, and we have the ability to collect it, but that's where that social contract balance comes in.
Yeah, I agree with that. And I actually feel like, from my perspective, I don't feel like the HIPAA is actually what's the problem in terms of our accessing the data. It is more system level challenges. I mean, I think people may misunderstand HIPAA to believe that it's prohibiting us from having access to information, but I don't believe that we need to have individual level data to actually be able to improve healthcare efficiency or care.
So I think one interesting follow-up question on this is what, how do we share that data most effectively with communities? And so in Heart Rescue, we have these hotspots, and there are many of them. And one method that seems to be very attractive is going into schools. And education is an existing social contract, right? We're supposed to prepare students for the real world, and there's nothing more real world than some of the real problems communities face in terms of their health. And so by going into schools, you know where the school is, you know it's in the middle of a hotspot, you know that students come from that hotspot. We've been amazed at what kids can do in terms of adopters of new things, new ideas, technology. So to teach a high school student and even junior high and even below that how to do CPR, and then to bring that into the home as a homework assignment to teach the family, teach friends, and then they come back and say, "Who else can I train?" And you start to think about, my gosh, it's like we ought to be sending people home with blood pressure cuffs and doing risk assessments. And let's talk about the stroke thing. I mean, people are waiting way too long to come in for a stroke, and so can we add that to the homework assignment? And so you really start to see a potential group of people who can be champions and learn to advocate for change in their own neighborhoods. And in our new era of population health, I mean, we could afford to pay them to do that. I mean, what a great deal. I mean, that's a new contract that we can make.
Something better than engaging youth on these kinds of things as well, because they establish the social norm among themselves, which carries on for generations. And so I really think that enabling and empowering our youth to have these skills and this knowledge, and also the ability to spread the information and to with their families as well as their peers is really, really fantastic.
And I would also say, I mean, along that line, the thing that I really like is just this idea of figuring out why people are doing what they're doing. So for students, if you go in and you educate them and you teach this, why do they tell their family and friends? What are the barriers that are preventing them from being healthy, and how do we break down those barriers to make it easier? So if we have students who are in a set location, they're in an educational institution, we can go, we can teach them CPR, they can take that home with them, they can teach CPR there. All of a sudden, we're increasing access to these skills or to this knowledge that they might not have had otherwise. So I really like this idea of figuring out why people are resistant to being healthy. Do people not practice good health care because they don't want to be healthy? I don't think that's the case. I think for some people it might be a lack of knowledge. For other people it might be, it's scary. I mean, if you're a bystander and you come up to someone having a heart attack, you may have taken a CPR class a few years ago, but what if I mess up? What if I do something wrong? And even if you're not going to be sued or anything like that, just there's a person's life on the line, and that's scary. So figuring out how to understand what it is that people are thinking when they're going into these situations, how we can make it easier for them to choose the healthy option and to choose the option that benefits us all, I think. It's a good thing.
One of the examples that brings to mind, you're right about the school being a great place to exercise some of these opportunities. It's a confined environment. Kids are mandated to go to school, and they spend a good deal of their time there. One of the examples we look at in public health, traditional public health, is nutrition education. And there's a great opportunity when you think about, particularly poor children, they're having their breakfast at school, their lunch at school, and their after-school snack at school. Most of their nutrition is coming in during the school day. Is there an opportunity to engage in more nutrition education in the school setting and using those traditional lunchroom attendants, the lunchroom ladies, to train them in nutrition education? That's an innovation that I've been thinking about for a long time.
Very simple.
Right.
Very simple to do.
So I'm going to use this opportunity to be a bridge to the workplace, because I think that we've talked a bit about schools and how they're great opportunities to engage youth in terms of adapting skills, gaining skills, but then also sharing information. But I also feel the workplace we believe from a public health perspective that for many of the public health issues, we can do a lot of employers take on the responsibility of assuring healthier workplaces, environments within their workplaces, because that's where adults spend the majority of their time. So I'll flip to an immunization example because that's what I feel comfortable with. But we know that influenza vaccination coverage levels are better when employers offer the vaccine in the workplace. Because it's not that people don't want to get the vaccine, it's just that they're so busy, so if the vaccine is brought to individuals in the workplace, they can get vaccinated there. But that also applies to other things, whether if it relates to access to healthy food, weed watchers programs, smoking cessation programs within the work environment, or even incentive programs within the workplace. So the healthy wellness programs that many employers are implementing. How well thought out are those? How well are those implemented? And really are they successful in helping their employees to be more healthy? And do the employers really understand the benefit to them from a business perspective about it? So I think, Emily, you have thoughts about this. So.
Well, yeah, and so I'm part of a workplace health research network, which is trying to talk about these issues. There are individuals who are looking at workplace health promotion and does it work? Because really what employers are trying to say is we want to make sure that our employees don't turn over as much. It's costly to employers to have to retrain their workforce. It's costly to lose really good employees. So if you can figure out ways of reducing accidents due to sickness, I think that environmental and occupational health scientists have been looking for a long time at how to improve safety in the workplace. So how to reduce, I think OSHA was it, how to reduce hazards in the workplace, whether that be obstacles, things that could fall on you, things that are unsafe, even just chemicals or hazards through the air, through the water. But there's also this idea of wellness and how do you protect their well-being. And so I think that's maybe the flip side that we're starting to see. Employers are trying to care about how do I keep my employees engaged? And one way is through this workplace health promotion, caring about them as individuals and caring about their health and wellness so that they can do the job that they want to do. So I think that's an important, and it's also an important intervention point. If you're trying to find people, they're at work for 8+ hours every day.
So I completely agree, and I can tell you, for example, at Baxter, with 50,000 employees, it was a smoke-free environment. There was no candy on the assistants' desks. There was fresh food. The gym was subsidized by the company and had a monthly charge of $5, which was a token commitment. And so I believe that companies are moving more and more towards providing that kind of work environment. My only concern is, and I don't have the statistics for it, but my concern is that employers where you have higher level of education workforces providing that probably provides less of an overall impact from a societal point of view than if we were to provide it where the more sort of like significant social and economic needs are. Right? Because awareness, I live in Lake Forest, I don't think there's anybody in Lake Forest who doesn't understand the correlation between healthy eating, exercise, and well-being. But I don't think that that should serve as an example for all of us thinking like that. And so I think we have to probably focus on those pockets where there is a strong correlation between socioeconomic status and health. And I don't think any employers there offer what I just described. And so there is an unfortunate disparity, right, between access to these sort of like benefits or perks for people that fundamentally could afford to get them anywhere else as well.
That's actually a really great point, because even in organizations that offer wellness programs, they tend to be offered to the full-time employees who are there. They're not necessarily offered to part-time employees or contract employees who could probably benefit most from it. So I think, that's definitely a place where more research needs to be done, and that's an interest of mine, is trying to figure out how do you convince employers of low-wage employees then to adopt some of these practices, which have been, that have high benefit in places like Google or these high-tech companies with a very educated population. How do we then translate those findings to employers of low-wage employees for whom the cost-benefit looks a little different, and how do we align those incentives?
Yes, I guess I'll take the moderator's prerogative and maybe the last comment because we have limited time. But I think that from my perspective, I would really like this, from a public health perspective, where we focus on really addressing the needs of the underserved and those who are least likely to get the services they need. If the higher economic groups and businesses and higher educated groups took care of their workplace, then we wouldn't have to think about that and could really focus our needs and resources on those who don't have it. And it may not be using the workplace or employers as a way to get to that population. But I feel like, at this higher level, if there was that responsibility on the workplace, then we would be allowed to focus really on those who really have no other means to get the kind of support that they need. So I'm being told to stop. And now we have 15 minutes for question and answer. So we have 4 questions. So I will read the question. Question number 1. As the panel talks about the regulatory aspects of healthcare, how much does access to healthcare play a role in societal rights to healthcare? Is there a need to re-examine current healthcare models to address access? In particular, is there a need to grant other types of practitioners, such as nurses and pharmacists, broader roles and responsibilities as providers as defined by Medicare and other regulatory bodies? So this is I guess it's really a matter of broadening. Do we have sufficient access, and does that play a role? And is broadening the scope of work for pharmacists and other non-traditional providers, not non-traditional, but nurses and pharmacists, to allow them to do more in the community to enhance access? So I'll open that up to the panel.
So I think the answer is yes. I think that there is a need for better access. Even with the Affordable Care Act, the emergency department visits in Chicago have gone up significantly. Our own emergency department, I think, like 15%. And it's a reflection that the health system is not able to, give access to everybody that needs health care. And there's some pretty sick people that are coming in. And clearly one of the things that we have to do better is to figure out how to have a better interdisciplinary care strategy for patients, because it doesn't make sense for specialists to take care of everything. So how do they interface with the primary care physician? We have tremendous costs in our system because there are behavioral health issues that aren't being taken care of. And so how in the world do we take care of that? And it's not, all the specialists in the world, they're not behavioral health specialists to help with that. Okay, so I think that we can do a much better job of coordinating that care going forward and working with community clinics more effectively in creating care coordination plans. And this is a workforce development thing. I think that beginning with our high school students, they could certainly help in areas. I volunteered as a high school student in the emergency department. That's how I got started. So I'm confident that they could do that. But there are community health workers. There are peer coaches. We have patients who have a certain disease that are having a really hard time with that disease, and we know that 3 blocks from them are at least 5 other people that have the same disease who are doing really well. Why aren't we connecting them? As long as we have their permission, we can start thinking like that. So absolutely, I think this is an exciting time to be thinking about interdisciplinary care teams.
I echo your sentiments, particularly about behavioral health. I think there are definitely issues related to access to behavioral health services, whether it's mental health or substance abuse type of services. And there's issues related to parity in terms of compensation from an insurance perspective. And I think we have to hold insurance companies accountable for assuring that services are available to their members. I think if these services are supposed to be covered and accessible, then they really have to support the development of those systems to meet the needs within their community.
Just one quick footnote to add to that. Clearly access is an issue. There's no question about that. The concept of innovative ways to address the healthcare workforce development gap, I think, is an opportunity for all of us. And in fact, we talk in the paper about the growing healthcare workforce, and certainly partnerships with organizations like community colleges to do certification programs and high schools, as you mentioned. The workforce is growing in terms of healthcare. The capacity to be innovative in that way, I think gives us all hope that we can address some of the access issues through that.
Yeah, and I think innovation is really a critical component here too. I think we talk about telemedicine or telepsychiatry in particular, or systems for teens to access mental health services by texting. There's a lot of opportunity that's out there, and I think it's a matter of us kind of finding those that are really successful models and bringing them in and supporting them in our environment. So question number 2. How does one reconcile social contract around healthcare with rights under other articles of social contract? For example, rate of healthcare expenditure, growth means ability to fund other critical needs, for example, education, environment, and infrastructure.
So this is looking at how trade-offs, that if we invest more in healthcare, we're somehow not, we may be investing less in some of these other domains.
That's the way I think it was. Is the person who wrote the question. Want to clarify? I think that's right.
So I'm just going to jump and then please jump in. My thought is that clearly there are limited resources. And so one of the things that we have to do is to figure out how to allocate these resources most effectively. I think that it's maybe somewhat short-sighted to think that if we invest in one thing, it means necessarily that we can invest in other things. For instance, if we invest in greater education of healthcare, there's the possibility that we can have a healthier population, but also a better educated population. So I think, at least from a first perspective, I think it's maybe short-sighted to think that investing in one thing means that we are not investing in another. At the same time, because there are limited resources, I think that some of the mandates from the Affordable Care Act are really saying that we need to think about the cost of healthcare. We need to think about quality outcomes. And so I think hospitals have been investing in ways of trying to streamline processes so that we can reduce costs and trying to figure out what are evidence-based methods for improving quality instead of just doing lots of different procedures that may or may not have a good outcome for the patient. But I don't know if anyone else has anything.
Yeah, I find it an interesting question because I think that we're looking at, from a public health perspective, we're looking at social determinants of health. Because we know that education, transportation, environment, housing, all those things that we think are foundational are really have struck. If we improve those elements, we ultimately improve health overall. And so if we are efficient about delivery of health care, that could free up additional resources to address some of these social determinants of health so that ultimately health care is improved and there's fewer health care costs overall. So it's somewhat cyclical, but I think the onus is on us right now to be more efficient about the delivery of our healthcare services. So there are additional funds available to address these social determinants of health, because without addressing those, we'll have this continued cycle of ongoing poor health.
I think just to build off of what you said, I think there's an incredible opportunity to build efficiency in the health system that could actually improve health and save money at the same time. And so, as just a couple examples, there are high utilizers of our health system that are a result of fragmented care, so we don't have good health information exchange that, we're sharing kind of care coordination strategies between different hospitals. And many of them have, a chronic disease, but also have a behavioral health issue that needs to be addressed as well. So I think that bringing that, coordinating that care better could actually reduce costs. And then, of course, the other areas is end-of-life decisions and palliative care. I think we're terrible as a health system to talk about what wishes are for loved ones, and I think we can do a much better job at that.
I think just a quick response would be that our government, our system is set up so that we have policymakers at the legislative and executive branch that we entrust as citizens to come up with setting those priorities. And I think we have to educate the policymakers, both legislative and executive, on how best to be innovative. And I think that that's really important that we keep in the background that we have this system in place that we can use. key to that is that the policies are proactive as opposed to reactive, like the example you mentioned at first with California.
So, it's question number 3. In light of the recent agreement to add a trauma center to Chicago's South Side, what is the role of government, public, private hospitals, corporate entities in the rights and privileges of healthcare? I think, well, from my perspective, I had a big sigh of relief when I heard about the partnership between Sinai University of Chicago and Holy Cross Hospital, because I know from most people's perspective, this has been an obvious need in the community, and it was fantastic to see these hospitals working together to address that need. I think from a health department perspective, we again worked with competing hospitals for the Ebola response. So we worked with Rush, University of Chicago, Northwestern, and Murray Children's Hospital. And oftentimes these hospitals have been in competition with each other related to patients, getting patients, providing care, who's better at what. But when it came to Ebola, we were able to bring these hospitals together to rally up the resources to coordinate a system that actually helped us to evaluate numerous patients who might have had Ebola, and then to evaluate them and provide them with care. And I think this example of the emergency department, or these hospitals working together to establish a trauma center on the South Side is fantastic. And public health was not involved with that, but I think it was a fantastic collaboration. And I suspect there was some governmental involvement in the discussions, discussions, but I think that end result is a positive one.
Yeah, and just this is an example. The public policy response. I know that there were a series of hearings, and Senator Maddie Hunter was at the forefront of driving that conversation, and to have policy champions that we can rely upon. Senator Hunter, I will give her a plug, is one of our people in our community that pushed for change, like establishing additional medical centers. So,
I think this is a good example. I think trauma is one example of, again, we're sharing resources among hospitals to take the best care of patients. There are many other examples that as we go forward, will focus on stroke care, on cardiac arrest care, heart attack care, and I think from the standpoint of how the government can help, I mean, we really do need to get better data on where trauma is occurring, what are the delays, where are strokes happening, where are cardiac arrests happening, and hospitals are getting reimbursed a significant amount of money to care for patients. It seems like is there a way to ask for some contributions to data, that we can use to more effectively take care of everybody.
It's curious that there's a statute that I've worked with for many years in Illinois called the Health Statistics Act, and it does not mandate the type of data that the Illinois Department of Public Health gathers. It says the Department of Public Health may gather certain data. And maybe one thing is to kind of push the envelope a little from a policy perspective and get the state to mandate some collection of population-based data through the Health Statistics Act.
I don't disagree with any of the comments that were made, but you made a comment earlier that addressed some of the socioeconomic issues we have, some of the infrastructure needs, some of the housing needs, and so on and so on. And I get a little bit concerned only because a trauma center on the south side of Chicago is the sort of like emergency attempt to control trauma in South Chicago. I wish we had better ideas about gun control, and actually you wouldn't have to go down that path in the first place. And it somehow really strikes me as really maybe addressing the problem, but not really dealing with the underlying root cause that actually triggered it. And that applies across many things that drive healthcare expenditures in our country. And I use this as an example on the other extreme. Right? I have 3 sons who play hockey, and anytime a player is bumped or pushed against the walls, the parents run to the emergency room for CAT scans and MRIs, and before you know it, they have spent $10,000 of healthcare costs on what I believe never required the procedure in the first place. And so it's all a matter of access that is either insufficient or it's excessive. But in one way or another, it escalates the cost to a point that makes us unique in the world.
I don't think anybody would disagree with you that we really have to get to the root causes to prevent the trauma from occurring. But in the meantime, that does make me feel better to know that there won't be a trauma center. Let's see, so in the white paper seems to regard any arrangement of health care provisions as fulfilling the social contract for public health, be it single payer or Obamacare or anything in between or beyond. Shouldn't we have some criteria to judge one arrangement as better than another in being a public health social contract? We need to grasp the institutional realities, political processes, and moral understanding at core of social contract in the U.S. so we can assess shortfalls or the fulfilling of the social contract.
Well, go ahead.
Well, I was going to say, I think that's a great comment. And I think, as you were saying earlier, judging healthcare in the United States against healthcare in other developed countries, we have very high costs and we have not quite as good of outcomes. So I think that when you're going forward, there has to be some way of evaluating. But I think also as we move forward with different plans for tackling issues in healthcare, I think that there has to be some reality of where we are and where we need to go. So even if the Affordable Care Act isn't exactly where we want to be maybe in the future, or maybe it is, I think given the reality of where we started, it's a step, and it's a step in a direction. I think that, evaluating whether it goes far enough, maybe single payer would go much further, is something important that we need to think about and that needs to be addressed in the public forum. But I think given sort of where we started from, it's also important to make some progress. And I think progress in a direction is better than not moving because we can't agree on something.
Yeah, I mean, policy change in our system is typically incremental. I mean, there are very few examples in the history of this country where we have monumental legislation, like the Civil Rights Act is an example of monumental legislation. I think the Affordable Care Act attempted to do that, but it's taking on such a complex part of our society. I think one issue, I've always been a little bit turned off by using the term Obamacare. I mean, it's, in my opinion, we're ascribing a policy change to one person. It was a systemic change, and I think we need to go back to calling it the Patient Protection Affordable Care Act, which is what it was originally called. We don't call other statutes by the name of the president that signed it throughout the history of our country. So I do take a little umbrage to that. But overall, I think it's a great question, and I think that we have to continue to look at. And I wanted to say this, that we have to make sure to balance the need for research and evidence-based practices and changes. What we preach in public health is research and evidence-based practices. At the same time, we have to have the courage to act on limited knowledge and insufficient evidence. So that's one of the balances.
I think this question highlights something which I think is the critical importance of community data. And wouldn't it be wonderful if our social contract, and this is doable to by ward, by representative district, say, here's your health report card. I mean, here's your cancer rates, here's your survival rates, here's the Illinois average, here's the national average. This is yours. Here's your rate of cardiac arrest. This is your rate of bystander CPR. This is your survival rate. This is the Illinois average. This is the national average. That is going to empower a community to have that dialogue. Is our current system working? Do we need to modify it?
No argument. Question number 5 and 6, I think, are to be read together. The U.S. is the most industrialized country that does not provide paid maternity leave. Other countries, even developing, provide between 1 month to 1 year of paid leave. Is this health care service for mothers a right or a privilege? What would be possible next steps to finance this as a social contract? And then, it's a separate, a different person asked this question, but I'm going to read it at the same time. Is innovation in medicine a crutch? Do Americans now consider access to innovative treatments a right and a magic pill for all maladies and ignore our own responsibilities for monitoring health and preventive interventions? So I think these are coupled because of addressing the rights and privileges, and we have 1 minute to answer.
So I just wanted to share a story. So I was sitting in an MBA class, and there were a set of German foreign exchange students sitting in the class. And we were talking about what to do in some kind of employment situation. And all of a sudden, the professor said, well, in this case, I'd probably just fire this person. And one of the German foreign exchange students says, you can't just fire them. And he's like, okay. In this room, how many of you have guaranteed sick leave? And all the German foreign exchange students raise their hands, and they look around. They say, what's going on? How many of you have paid maternity leave? The German foreign exchange students raise their hand, and they're like, how do people live? and I think the interesting thing is that, sometimes what we don't know, we don't think about. So in the United States, I think, if you have a job for a long time, you might have sick leave, just as part of your job. It's not actually mandated, but many employers offer that. Same thing with maternity leave. Depending on the organization, there have been a lot of organizations now in the news that are offering paid maternity leave. And I think that in the United States, we just think about these things as being benefits that come along with your job. They're part of the organization, the contract that you have with your employer, with the organization. So it's interesting when we're thinking about these things, it's also how we're framing it as a country. Is this something that should be mandated as a right? Is it something that should be negotiated as part of the contract between the employee and the employer? And what does that look like if it's different? Did the Americans in the room think that they were worse off than the German foreign exchange students? Well, probably after class they did. But beforehand, I don't know if they would have known the difference. And so I think as we're thinking about these things, it's also how are we framing it? And how do we explain that to people in a way that makes sense? What does it mean for us to have these different contracts?
So I think we're almost out of time. Does anybody on the panel want to address the last question, which was related to innovative treatments as a right and allowing us to ignore our responsibilities for monitoring health and preventive interventions?
So being in that industry and spending my professional life there, I give the answer, I believe it is a right to have access to the most innovative therapies, as long as there is data that supports that particular therapy adequately addresses the disease that is targeted with that therapy. And I do believe as we move forward, healthcare costs in the United States have to come down also by it no longer being the country that pays the highest prices for pharmaceuticals. What the impact of that will be for the industry is hard to gauge, but I think it will be pretty drastic. But at the end, I am of the opinion that because we are able to innovate and provide truly innovative solutions that make a difference, it goes back to asking questions that we have asked, namely identifying where we have so much unnecessary spend and fluff in the system that it can't all be incremental. I think it has to be a matter of substituting inadequate therapies with better therapies, and I think that has to be the approach. If it's all incremental, I think the system cannot possibly carry it.
So as the moderator, I will also take the priority again to make one last comment related to the issue. Because as you're talking, I was thinking about my work with immunizations. The CDC has an advisory committee on immunization practices, which makes recommendations for vaccination throughout the U.S., both for adults and for children. And what's been factored in the past 10 years into the evaluation of whether or not a vaccine should be recommended is the cost effectiveness of the vaccine itself. And so they look at the cost of the vaccine, and then they look at how much of an impact it has on the burden of disease in society. They look at societal costs, and they look at all those factors to decide whether or not a vaccine is routinely recommended or whether it's recommended for a subpopulation. And I feel like that's actually what needs to happen more routinely with innovation, in terms of the effectiveness of the intervention as well as the cost overall, to see whether or not they're really worthwhile and should be used broadly within a community. Because I think it is. We really have to weigh whether or not, and that's how we will control some of these healthcare costs now you only have 8.5 minutes instead of 10 minutes for your break. I do want to thank everybody for their time and attention to this discussion. I want to thank the panelists for this fantastic discussion. Minutes that remain, 8.5 minutes we have for the next session. The next session in this room is Energy Works, how do we power a city? Thank you all for your participation and enjoy the rest of the afternoon.
That was really good.